Hey everyone, welcome to This Explainer. Today, we're taking a really deep dive into the world of hematology to unravel a pretty serious and honestly highly complex condition, acute myeloid leukemia, or AML. Now, if you've ever glanced at the medical literature on this, you know it can feel like staring at a mountain of jargon. But don't worry, we're going to get through it together. I'm actually really thrilled to guide you through this, because we're going to break down these intimidating concepts into clear mechanical processes that make complete sense. By the time we wrap up, you'll see exactly how this disease operates, literally like a piece of broken machinery. Okay, let's dive into this. Whenever you're studying a blood disease, it is incredibly easy to just get totally lost in the weeds. So to prevent that, I want you to keep this guiding question in mind as our true north. Which cell is affected, what specific abnormality occurs within it, and what is the ultimate result? Honestly, if you can answer those three things, you can understand pretty much any hematological disease. Here's a quick look at our agenda for today. First, the basic mechanism of AML. Then, we'll look at normal hematopoiesis failure and its symptoms. Third, the treatment flow toward remission. Fourth, how chromosome abnormalities dictate prognosis. And finally, we'll compare the two classification systems, FAB and WHO. All right, Section 1, the basic mechanism of AML. So, as you know, our bone marrow is constantly churning out new blood cells. But occasionally, a genetic mutation happens in an immature blood cell. Now, a single mutated gear isn't enough to cause AML on its own. For this disease to really take hold, two very specific genetic switch failures actually have to happen at the exact same time. Step 1, the proliferation switch gets jammed in the on position. This means the cells just start multiplying endlessly. But, if they just multiplied and matured normally, we just end up with a lot of healthy cells, right? That's exactly why step 2 is so devastating. The differentiation switch gets flipped completely off. So these multiplying cells completely lose their ability to mature into functional, useful blood cells. Think of it like a busy highway where the off-ramp is totally blocked by a massive accident. Because the cells can't mature, meaning they can't take the exit, they just pile up. You end up with this massive, catastrophic backup of useless immature cells, which we call blasts. This cellular traffic jam just overflows the bone marrow and eventually spills right out into the bloodstream, completely overwhelming the body's normal operations. Which brings us to Section 2, normal hematopoiesis failure and symptoms. So the crucial takeaway here is that as these leukemic blasts take over the bone marrow, they literally crowd out the normal blood-producing factory. The result? The body just stops making healthy cells. Without healthy neutrophils, the body's natural immune defense collapses, leading to severe fevers and infections. Without enough red blood cells to carry oxygen around, the patient suffers from profound anemia, extreme fatigue, and shortness of breath. And without platelets to clot the blood, well, the patient develops a severe tendency to bleed. These are the classic immediate red flags that usually rush a patient into the hospital. But the damage doesn't stop in the blood. Because these overproduced, totally useless leukemic cells are circulating everywhere, they physically invade and infiltrate other organs in the body. So this isn't just some abstract microscopic issue. Patients can actually physically manifest swollen gums, massive enlargement of the liver or the spleen, and even form literal tumors right under the skin. The body is just overflowing with cells it absolutely cannot use. Okay, Section 3, the treatment flow towards remission. To really understand the treatment, you first have to grasp the sheer scale of the problem. When a patient is newly diagnosed with AML, they're carrying roughly 1 trillion leukemia cells in their body. 1 trillion. To put that into perspective, the average human has about 60 trillion cells in total. That means at the exact moment of diagnosis, 1 out of every 60 cells in their entire body is a useless, dangerous leukemia cell. It is an absolute crisis. Because the volume of cancer cells is so incredibly high, the immediate goal isn't necessarily a 100% total cure on day 1. The first vital milestone is achieving what's called remission. Remission basically means using intense chemotherapy to blast away those leukemia cells, reducing them to a tiny fraction of a percent, specifically under 5% in the bone marrow. By clearing out that cellular traffic jam we talked about, we finally give the normal, healthy blood stem cells some room to wake back up, recover, and start producing those life-saving red blood cells, white blood cells, and platelets again. Let me tell you, the journey to remission is grueling. It kicks off with remission induction therapy, which is this massive, intense wave of chemotherapy given over about a week. And because this wipes out basically all the blood cells, both good and bad, the patient's blood counts drop to near 0 for about a solid month. During this really perilous time, they rely entirely on constant blood and platelet transfusions just to survive. Finally, after about a month, if the healthy cells bounce back, a bone marrow test is done. If remission is achieved, they move on to consolidation therapy to wipe out any microscopic leftover cells. But if the chemo fails or if the disease comes back, doctors have to bring out the big guns, a full stem cell transplant. The really harsh reality here lies in the odds. Despite how incredibly aggressive that first month of chemotherapy is, only about 60% of patients will successfully hit remission on the first try. The other 40%, they unfortunately have to restart the fight and undergo induction therapy all over again. Let's move to Section 4, Chromosome Abnormalities Dictating Prognosis. So you might be wondering, why do some patients respond beautifully to chemo, while others resist it completely? To answer that, we have to look at the genetics. Now, please don't have an allergic reaction to the word genetics. We're going to keep this incredibly simple. Think of chromosomes as the instruction manuals for the cellular factory. In AML, sometimes huge chunks of these manuals get physically ripped out and swapped with one another. This is called a translocation. When two completely different manuals are spliced together like this, they create a mutant instruction, a fusion gene, that tells the cell to behave in terribly abnormal ways. Let's look at one of the most famous examples, the T821 translocation. Here, a piece of chromosome 8 containing the ETO gene and a piece of chromosome 21 containing the AML1 gene literally break off and swap places. This creates the mutant AML1 ETO fusion gene. Remember earlier when we talked about the differentiation off switch? Well, this exact genetic mix-up is the literal finger flipping that switch, permanently halting the cell from maturing. And this vividly illustrates exactly why understanding these genetic blueprints is absolutely crucial for treatment. The specific genetic mutation a patient has completely dictates their prognosis. If a patient has a favorable mutation, like the TA21 we just looked at, they have a pretty solid 60% chance of being cured with chemotherapy alone. But look at the bottom row. If they have an adverse genetic profile, like maybe a missing piece of chromosome 5 or highly complex chromosomal chaos, the cure rate with standard chemotherapy alone is basically zero. These adverse patients absolutely require a stem cell transplant to survive. Finally, Section 5, the two classification systems, FAB and WHO. Historically, doctors only really had microscopes, right? So they created the FAB classification. You can think of this as a result-based system, categorizing the disease based purely on what the damaged leukemic cells look like visually under a lens. But as modern medicine advanced, we developed the WHO classification. This is a cause-based system. So instead of just looking at the visual damage, it categorizes the leukemia based on the underlying genetic trigger, like those translocations we were just talking about. Let's see how this builds a larger picture. The FAB system categorizes AML from M0 all the way to M7. And while it might look like a complex jumble of medical terms at first glance, it actually follows a highly logical sequential order. It basically traces exactly how far along the cell maturation pathway the factory broke down. For example, M1 and M2 represent breakdowns at the earliest myeloblast stage, often showing these sharp, needle-like structures called hour rods. M4 and M5 happen a bit further down the monocyte path, creating cells with a distinctively wide cytoplasm. It's simply mapping out exactly where that traffic jam occurred. Now, what's really fascinating here is a medical anomaly known as acute promyelocytic leukemia, or APL for short. Usually, a single visual appearance in the FAB system could actually be caused by several different genetic triggers, but APL is the grand exception. Under the visual FAB system, it is strictly categorized as M3, and under the genetic WHO system, it is strictly caused by one specific mutation, the T1517 translocation. It's a perfect, distinct one-to-one match between the genetic cause and the visual result, which makes it entirely unique among all the AML types. Which brings us full circle to a pretty profound thought. We started by asking which cell, what abnormality, and what result. We've seen that just one or two broken genetic switches can completely shut down the body's blood factory and unleash a trillion rogue cells. But if we can now identify the exact cause, the exact broken switch, like an APL or the T821 mutation, it begs a massive question for the future of medicine. How close are we to moving past the grueling, blast-everything-away approach of traditional chemotherapy and instead using targeted gene therapies that simply reach into the cell and flip the switch back on? It's a completely fascinating frontier in hematology, and one that absolutely holds the promise of transforming how we treat this incredible disease. Thanks for joining me on this deep dive.